Okay, good evening, everybody. Welcome to this another session of Pericardium. I hope you can hear my voice. Anybody who's sitting over here can raise his hand that he's listening to my voice clearly. Thank you. So let's move on. Today we are going to discuss about the most important topic, that is the topic of pericardium. And I'll be very simple in discussing pericardium as far as basic course is concerned. So that's why let's move on my slides from this present pericardium slides to the presentations. As usual, at the end of this talk, I would ask you questions by raising your hands, and I'll try to answer those questions one by one in a shortest possible time. Look, now this is the most important thing in pericardium is when we talk about diastole and systole. What do you mean by systole when I'm talking of pericardium? If I'm talking of pericardium, my systole is from beginning of QRS complex to end of T wave. It means to say that I'm talking of pericardium. The cardiac systole is ventricular systole. When I'm talking of diastole, it means I'm talking of ventricular diastole. That's what it means by. So if I say systolic collapse of RV, it means the RV is collapsing during systole. If I'm saying diastolic collapse of RV, it means RV is collapsing during diastole, that is at the end of a T wave to beginning of QRS complex. That is the first and foremost part of this presentation is. All of us understand our heart is enclosed in 3 layers of pericardium, 2 layers of pericardium, visceral and parietal pericardium. The closer one is visceral pericardium, the distal one is parietal pericardium, and in between these two pericardium, there is a potential space which contains a potential fluid which helps in the movement of this contraction and relaxation of the heart. Very much various people say almost 50 ml of pericardial effusion is present in this subset of populations. But the question is, this pericardial fluid is not seen as long patient is in diastology, and whenever the LV contracts, the pericardial separation is seen in a couple of subjects. If you ask me in 2024, what is the most important modality to discuss about pericardium, whether it's echo or a CT, my answer will always go towards CT because CT gives you all around information of the pericardium rather than one slice of a pericardium which we are seeing in echocardiography. So whenever you are doubt, especially your thickening of pericardium or the constriction of the pericardium, always take an help of cardiac CT. Now let's come down to one by one. What is pericardial thickening is? What is epicardial fat is? What is intrathoracic fat is? Once we start looking at the pericardium, moving on then become acute pericarditis. What is acute pericarditis? Then comes pericardial effusion. What is normal? What is diffuse? What is localized or loculated? And last is what is effusive constrictive pericarditis? And couple of answers between constrictive versus restrictive pericarditis, restrictive cardiomyopathy. So that's what we are going to discuss over a period of next approximately 1 hour. Now, when we talk of a pericardial thickening, this is what we start looking at the pericardial thickening. All of us understand we have an endocardium, we have a myocardium, then we have a pericardium. The pericardium is between visceral and parietal pericardium, and this is what the visceral and parietal pericardium is. And once we look this visceral and parietal pericardium is, we look in multiple views, and the most common view which we employ in a day-to-day practice is a plaques view. And how do we do it? We reduce our gain to a large extent, like and this pericardium will start separating out, because as you reduce the two-dimension gains, the other structure will start disappearing and the pericardium will be seen clearly out there. Same, if you do a CT, look how beautifully you can evaluate the thickness of a pericardium. Is not only along with the LV free wall, but other side also you can see it very clearly, this pericardial thickening. Anything more than 5 millimeters is considered as abnormal. When pericardial thickening is significant, a lot of calcium get deposited. It starts showing a reverberations as it shows in prostatic valves, especially the mitral valves. And look at this thick pericardium, which is just stopping short of left atrium. And this shows a lot of reverberations or shadowing in the structure below it. Next question is, we often ask this question very commonly. One is obesity. Second is epicardial fat. Epicardial fat is a fat in between the visceral and parietal pericardiums. And any fat outside the pericardium is known as paracardiac fats. So remember this word very significantly, because paracardiac fat is a surrogate marker for obesity. Epicardial fat is a surrogate marker for atherosclerosis. So that's how the difference happens. So we have a pericardial thickening. We have an epicardial fat or paracardiac or intrathoracic fat. Now, moving on from that pericardial fat, we have a pericardial effusion. Whenever there is separation of visceral and parietal pericardium, we develop an evidence of pericardial effusion. And the same thing, when the visceral and parietal pericardium separates, during diastole, if we happen to see a separation, this is known as pericardial effusion. Now, here is an example. A patient of thickened pericardium, look how thick and bright pericardium he has got. And there's evidence of pericardial effusion in between. Thickened pericardium with pericardial effusion. Now another structure showing almost the same thing, the presence of pericardial effusion in this patient. Thickened pericardium with epicardial fat. Now the same intrapericardial structure is being opacified by presence of epicardial fat. So here is an epicardial fat. And here is another example for epicardial fat. Here is a visceral, here is a parietal pericardium. Here is epicardial fat, and outside the parietal pericardium, there is also fat which is present over here, which is known as paracardiac or intrathoracic fat. So now a big example, thickened pericardium, epicardial fat. Here is a pericardium, and there is a lot of fat which is present seen over here, which is known as intrathoracic fat. Again example, here is epicardial and here is intrathoracic fat. This is one clinical update from 2013, just summarizing about the body fat deposits. Epicardial, paracardial, pericardial, the sum of epicardial and pericardial fat is known as pericardial fats. Perivascular, ectopic and visceral fats. We are not bothered about anything, we are more bothered about epicardial fat, which shows visceral intrapericardial fat continuous with the myocardial surface, delimits by epicardium and visceral pericardiums. That's what we need to look whenever we are talking of epicardial fat. We move on from a thickness of pericardium. We move on to the epicardial fat. Then we move on to intrathoracic fat or paracardiac fats. After that, the most important thing comes acute pericarditis. And I'm very sure all of us must have seen this acute pericarditis along with myocarditis during our COVID times. What is that? It's a clinical syndrome diagnosed based on two of the following criteria. Patient develops a chest pain and a pericardial frictional rub. And if somebody has not heard a pericardial frictional rub, just rub your hands together. If you rub a hand together, whatever the sound is produced, If you put it in the same heart rate, about 60 to 80 beats per minute, so you start hearing a pericardial frictional run. And that's what is classical, because during systole and diastole, the epicardial and parietal pericardium, they're rubbing with each other, producing a pericardial frictional run. Characteristic ECG changes. It's not the dome shaped, is a curve shaped SCT wave changes, which are seen in ECG. And then we have a separation of epicardial and epi and visceral pericardium to show an evidence of paracardial fat, a pericardial effusion during diastole. So we have two of these findings, and plus supporting finding. If somebody develops a acute pericarditis, inflammatory markers would be high in forms of WC, ESR, C-reactive proteins. Then we have an imaging modalities talking of inflammations, and this is not being done in our country to a large extent. Looking at CEA, CMB1 and makeup proteins is promising. Etiology of pericarditis. Till COVID, we always used to complain of pericarditis being caused by tuberculosis in our country. During COVID, we started blaming it to virus. And other differential diagnosis, the most common cause is ST elevation MI, post MI when we develop a Dressler syndrome consisting of acute pericarditis. But we have seen many examples of pericarditis. Apart from all these, there are a number of other causes for acute pericarditis. This is a classical ECG. If you happen to look at the ECG, this is curvilinear. It's not dome-shaped ST elevation. And it's seen in generalized all the leads of the ECG. So that's what is suggestive of. The picture looks like an acute MI, especially the inferior wall MI, but truly the picture is not so. So we have pericardial fluid seen in between the visceral and parietal pericardium, especially during diastole. Look, it is ends diastole, and we have separation of this fluid. And we see a normal separation, which is not abnormal in systole in majority of subject in during practice. Now, the work comes. Pericardial effusion could be diffuse symmetrical with clear separation all around the pericardium. Echogenic area anteriorly and none posteriorly is pericardial fat, not pericardial effusion. What does it mean by? If you're doing this in Plaque's window or subcostal window, if you happen to see anteriorly fluid but no fluid in the posterior chamber, possibly we are not dealing with true pericardial effusion. And I don't say 100% no, but to some extent we have to avoid it. Now, this is which is very, very important. When we do a subcostal window, we have to differentiate whether this is a pericardial effusion or pleural effusion. Majority of time, they could be alone or they could be together. Or it could be pure pericardial effusion or pure pleural effusions. So how do we differentiate whether this is pericardial effusion or pleural effusion? Remember a very simple sign. Pericardial effusion will always stop short of left atrium or a coronary sinus, where the pleural effusion goes all the way behind the left atrium and the descending aorta. Or in other words, the coronary sinus, which lies in left atrioventricular groove, it's an intrapericardial structure, and that's where the pericardial effusion will stop. And if it goes beyond this, then we are dealing with extrapericardial fat. Now, let's look at an example. Here is fluid which is present. The fluid is going all behind into the LA. So possibly this fluid is pericardial pleural effusion. At the same time, we see some amount of fluid in this cavity which is separated by visceral and parietal pericardium and stopping short of LA or just at the level of sinus. So if we are looking at a descending aorta, here is a descending aorta. If you are looking at a descending aorta or a coronary sinus, but I always say is just look at the coronary sinus and look at the trace of fluid which is ending at the coronary sinus. This is what we are dealing with, pericardial effusion. And if you happen to see a fluid behind this coronary sinus, always think of pleural effusion. One of the very important cause of a pericardial effusion is in our country is anemia and hypoproteinemia. Second, majority of cases who present with pericardial effusion, if they have a dilated cardiomyopathy, they have a small amount of fluid behind the visceral and parietal pericardium, which is secondary to congestive cardiac failure. And if you look at their chest X-ray, the fluid would be more on a pleural effusion on the right side and less on the left side, suggesting that this effusion in pleural cavity is because of congestive heart failure. And on top of that, there is evidence of pericardial effusion in the same set of population. All of us understand that is not because of any infective pathology. It's because of a heart failure or congestive leading to accumulation of fluid in the pericardial cavity. Now, how do we say small, medium, and large? And this is an arbitrary classification. Any space separation less than 1 centimeter versus more than 2 centimeter. If it's less than 1 centimeter, we talk of small pericardial effusion. If it's more than 2 centimeter, we talk of large pericardial effusion. And somewhere in between is 100 to 500 ml of pericardial effusion. But important thing is the amount of fluid which collects gives rise to pericardial effusion. But at the same time, at which speeds it collects give rise to pericardial tamponade. What does it mean by what I said? If the 100 ml of fluid is collecting very slowly, it's not going to produce a pericardial tamponade. 500 ml fluid which is collecting over a period of time may not give rise to pericardial tamponade. On the contrary, if 100 ml fluid collects very rapidly in the pericardial space, it can produce a pericardial tamponade. And that's what I'm going to repeat in a couple of minutes. And what I was saying a few minutes back, we have an evidence of post-operative, infarctive pericardial effusion, which is more common in the country, traumatic, malignant, post-COVID versus COVID myocardial pericardial effusion. And another very important thing, which always miss when I'm talking about, is heart failure. And we do see very commonly this kind of pericardial effusion in our clinical practice when the patient comes with a heart failure, especially the heart failure with preserved ejection fraction or HFpEF, or patient with atrial fibrillations. So I need not go into detail of talking about the pericardial effusions. The only thing I would like to say that if you happen to see some amount of fibrins or intrapericardial cavity deposits, like they are seen over here, the same thing which is zoomed up over here. And here's our descending aorta. Here is the left atrium. And look, this pericardial effusion is stopped just short of descending aorta. Coronary sinus must be over here. And this is all pleural effusion. So this patient has got not only the pericardial effusion, and this patient has got the pleural effusion, and intrapericardial, we see echogenic shadows, possibly suggestive of exudate rather than transudate. Where do we see all these kind of a thing? If you really ask me, where I do see a pericardial effusion, the most common windows are Plaque's window and a subcostal window. I showed you the Plaque's window over here. If I happen to see anteriorly as well as posteriorly, I am very happy. I only see a posteriorly, I have to really look for anteriorly. And what do? I go to subcostal window to see a fluid anterior. And when we see fluid on both sides, then we are pretty sure that we are dealing with pericardial effusion. But this separation should be seen in diastology, not during systole. At the same time, we can see an apical four-chamber view. My subsequent slide will try to show you all that. Now look at this patient who has got a large RA, he is IVC, and large amount of what? Pleural effusion is not pericardial effusion. Here is pericardial effusion. Here is pericardial effusion, but there is no pleural effusion over here. So we look at virtually all windows, parasternal, subcostal, and apical window. Distinguish from pleural effusion. Size, I told you already, but this is not a dogmatic or a characteristic one. It gives you a rough idea how much this fluid is and why so. Because if the pericardial fluid is exudate, is bound to produce a septation, it's bound to give a septation in the pericardial fluid, giving rise to, instead of a diffuse, it produces a loculated pericardial effusion. So our idea is first to look for a pericardial effusion. And once we have seen a pericardial effusion, we should see that whether this pericardial effusion is small, moderate, or large. And on top of that, whether it is diffuse or loculated. Now the important question comes is, if you happen to see a pericardial effusion, then you have to decide whether this pericardial effusion has got any tamponade physiology. What is tamponade is? It's producing a constriction around the heart. Not because of thickened shell, but because of the presence of large fluid in which the heart is hanging or swinging. How do we do that? We move to the next step where we see how do we see a pericardial tamponade. First of all, you must understand what is pericardial tamponade is. And for that, we have to understand this particular slide. Look, there is the intracardial pressure and there is the intraventricular pressures or intra-atrial pressures. Normal pericardial pressures are much less than intra-atrial or intraventricular pressures. And all of us have learned over a period of last 3-4 months that my right atrial pressure is 5 to 10 millimeters of mercury and my right ventricular pressure is 25 millimeters of mercury. So what does it do? If my intrapericardial pressure rises more than 10 millimeters of mercury or 5 millimeters of mercury, depending on RA size and IVC collapse, then it produces a pericardial tamponade. If this pressure goes up more than 25, it will produce a right ventricular tamponade. And if this pressure goes up more than systemic pressure, it will try to produce a left ventricular collapse. And there is no collapse of LA. And why there is no collapse of LA, I'm going to ask you at the end of this session. And I'm going to take attendance in this session also. Because what we feel, many people, they leave in between and then they try to claim the attendance later on. So my question, what I'm going to ask you, what is the intra-atrial pressure? In left atrium, how much pressure is needed to collapse LA? Okay. So this is what is the most important thing is. Next important thing is what? The next important thing is the rapidity with which the intrapericardial fluid collects. If it collects over a period of time, the pericardium has got a place to adjust that particular fluid. If it collects suddenly, the pericardium does not have that acclimatization to adjust that particular fluid. and it causes immediate tamponade. And that's what I said. Even if you have a 500 ml of fluid, it may not cause tamponade if collected slowly. On the contrary, if you have 100 ml of fluid, it can produce tamponade if it's done quickly. Now, what is the pericardial tamponade is? Pericardial tamponade leading to intrapedical pressure more than 15 millimeters of mercury. Cardiac compression will reduce filling of right atrium and left heart. Increase on equalization of intrapericardial right heart, PA diastolic and pulmonary capillary wedge pressure. Decrease cardiac output and BP with increased heart rate and peripheral vascular resistance. This is language what you talked. So let's talk about in practical sense what we are looking by clinical as well as echocardiographic features. If somebody has a pericardial tamponade, the most important thing the patient will develop a low blood pressure. Why he'll develop a low blood pressure? Because there is not adequate filling of RVR. And he'll find elevated venous pressure in the form of engorged next vein, and there's evidence of pulsus paradoxus, which will come over a period of time. Why the patient is shocked? Because there is no evidence of this poor filling of RV pressures. Now, let's talk of the features of pericardial tamponade. At this point, first of all, I'd like to explain you. During inspiration in a normal subject, the inspiration leads to increase in intrathoracic pressure, leading to increase of a blood flow from IVC to RA and RA to RV. So the tricuspid flow velocity will increase. On the contrary, if I'll breathe out, the expiratory, during expiration, the myocardial velocity will increase. And that's what, if it does a acceleration of respiratory movements, and that's what is the foremost important thing in cases of pericardial tamponade. I hope you'll be able to understand what I mean to say. And when we see this reciprocal respiratory changes, which gets exaggerated in filling pressure, and then what we get is a respiratory movement producing more than 25 to 35% of LV and RV filling patterns. And this LV and RV filling pattern is seen in mitral and tricuspid flow velocity. Second happens when this kind of phenomena happen in pericardial tamponade, you will find reciprocal respiratory changes in the RV and LV volume, and that's what we say a septal shifting or paradoxical septal motions. And this gives rise to RA systolic collapse. Now my word is systolic collapse because RA always collapse during diastole. And if you happen to see RA systolic collapse more than 1/3 of a systole, then we possibly think of pericardial tamponade. On the contrary, same thing happens in RV, but it's not a systolic collapse, it's a RV diastolic collapse. Then we have a reduced early diastolic tissue Doppler velocity. What is early diastolic tissue Doppler velocity? Is E prime velocity. And IVC is plethoric. Plethoric means dilated IVC which does not collapse with inspiration. And there's no change seen with IVC with inspirations. I'll explain this one by one. Moderate to large pericardial effusion, look at the separation in LV, look at the separation on the other side, and we can see all around the heart there is a pericardial effusion. Here is pericardial effusion with evidence of RV diastolic collapse. IVC plethoric, dilated IVC, dilated hepatic veins, and plethoric IVC. And this is what we have marked is systolic collapse of RA seen and diastolic collapse of RV seen. And here is a diastolic collapse of RV, which is getting bulged into the right ventricular cavity. And look at the reciprocal respiratory changes. Now, this is mitral or tricuspid. If inspiration, it is increasing, this is a tricuspid flow pattern. If it increasing during in mitral flow pattern, it will be a, sorry, if it increasing, it will be a tricuspid flow pattern. If it decreasing during expiration, it will be a mitral flow pattern. So here is the person who has got increased flow patterns with inspiration and with expiration, which is decreasing. And this variation is more than 25. If I happen to measure this A wave versus this E wave of this, E wave of this, the respiratory variation as seen over here is 69 versus 81. Then increase RV filling with first beat after expiration. Inspiration. I'll show you these patterns because this is very, very important. What is exactly I mean to say is, during inspiration, the flow velocity across tricuspid will increase and they will show more than 25% of variation in tricuspid as well as mitral flow patterns. And this is what is seen. The inspiration, the flow velocity is rest. The expiration, the flow velocity is going up. And that is what suggestive of mitral Doppler spectral flow. Same thing, fortunately seen in aortic flow pattern is mitral and aortic, they will go in the same fashion. Inspiration, they will decrease. Expiration, they will increase. Pericardial tamponade is constricting both. This is LA, this is LV. So it's constricting both LV and RV. It means the intrapericardial pressure is more than 120 millimeters of mercury. Now, what is pathophysiology of this pericardial tamponade? Why these respiratory variations are there in this subset of population? And that's what most important thing is. If you happen to understand this particular phenomena, my life, my work would be extremely easy. Now listen carefully. There's a large amount of pericardial effusion which is seen around the heart. So what this pericardial effusion will do? It will not let the heart expand when it needs to. This pericardial effusion will give rise to IVC, plethoric IVC. And that's what I said, IVC is plethoric. Now the next movement is, as soon as the patient inspires, lot of blood will come from IVC to RA, RA to RV, and this chamber has to enlarge to accommodate that blood. Since there is all around the shell like a fluid which is surrounding the heart, which is not letting the heart to expand. But how do I accommodate my fluid into the heart? What do I do is, I shift my interventricular septum towards the other side to adjust my fluid into the heart. So what happens? During inspiration, the tricuspid flow velocity will increase, and during expiration, the tricuspid flow velocity will decrease. Is that clear? If my heart interventricular septum shift to left side, so what will happen to mitral flow pattern? During inspiration, it will be reduced, and during expiration, this septum moves to other side, and the expiratory flow velocity will increase on the mitral side. So it's a septal shift. Look, with inspiration, the septum will move on the other side. With expiration, the septum will move to the other side. And that's what we number of times see in pericardial effusion, the so-called paradoxical septal motion of intraventricular septum. I hope this is my point is clear. When we have this intrapericardial paradoxical septal motion seen in pericardial tamponade is, during inspiration, the flow velocity will increase. During expiration, the flow velocity will reduce in tricuspid, and vice versa in left ventricle. And this is known as ventricular interdependence. I wanted to explain what inspiratory increase in tricuspid flow velocity, inspiratory increase in pulmonic flow velocity, inspiratory decrease in aortic flow velocity, inspiratory decrease in mitral E velocities, inspiratory decrease in LV dimensions, and increase in RV dimensions. And if I can put it together, I can say that with inspiration, the tricuspid and pulmonic velocity will increase and RV size will increase. On the other hand, mitral and aortic flow velocity will decrease and the LV size will decrease. And that's what happens when you talk of pericardial tamponade, along with RV, RA, and LV collapse. And there's no collapse of LA because there's no evidence of pericardium behind the LA. Let's move on further. When we move further, so what we get with deep inspiration, we get a low volume pulse as we often record in COPD surgeries. Heart is surrounded by a large amount of fluid which is not letting heart to expand. So people, they develop hypertension despite the fact patient has got plethoric eyes. We find engorged neck veins. We find low cardiac outputs. Two-dimensional echo, we may have a pericardial effusion. We could have a RA systolic collapse or RV diastolic collapse. Reciprocal changes in RV and LV volume, that is ventricular interdependence. The word is ventricular interdependence. And this is very important because every physiology is explained by ventricular interdependence. And IVC is plethoric. Plethoric means dilated more than 21 millimeter in size. And on top of that, it does not collapse with inspiration. Plethoric IVC in pericardial tamponade. So once you look at all these kind of a thing, only one factor which is left behind is what? A Doppler flow pattern. And how do we look for a Doppler flow pattern is, as I explained earlier, my Doppler flow pattern will have an evidence of inspiratory and respiratory, inspiratory and expiratory, RV. With inspiration, I'll find increase in tricuspid and pulmonic flow velocities. With expiration, I'll find reduction in tricuspid and pulmonic flow velocity. With inspiration, my mitral flow velocity will reduce. With expiration, they will increase. And that's what the Doppler findings of the pericardial effusion is. So in nutshell, if I have to remember all these things together, what I say is I divide these patterns into three parts. One part is what we see every time, clinical findings. Based on that, we try to make a diagnosis. We go to two-dimensional echo and look for only two-dimensional echo for anatomical structures. And third, we look at a Doppler flow finding in pericardial tamponades. Now, important issue is we can see the pericardial effusion or tamponade with very small amount of fluid also. And this happens during cardiac surgery, coronary interventions, transseptal punctures, pacemaker wire perforation, CVP line perforation, aortic dissection, and chest trauma. And whenever we see this kind of finding, we always try to look for the cause What could be the possible causes? Have you ever seen some surgeon what they were doing? If you are doing a long angioplasty, they always go and check with echocardiography any evidence of pericardial effusion is there or not there. Why do they do that? Because they are doing that to check whether we have produced any iatrogenic we have produced any iatrogenic perforation or not. And that's how they always look at this pericardial effusions. We learned about pericardium. We learned about pericardial effusion. We learned about pericardial tamponade. Now, over a period of time, this pericardial tamponade, the fluid either you take it out or get accumulated and finally gets absorbed, producing a constrictive kind of features. And if you happen to see a fluid along with constrictions, the feature of constrictions, we call them as effusive constrictive pericarditis, which is a feature for long-standing pericardial effusion. So how do we look at these subset of population is? We look at these subset of population is by looking at the picture where we have thickened pericardium along with pericardial effusion. And that's what I explained to you. If you happen to have a thickened pericardium with pericardial effusion, we start looking at effusive constrictive pericarditis. So here is the aorta, here is the LA, here is the LV, here is the RV on top. Look at the thickening of this pericardium and the presence of organized pericardial effusion in this patient over a period of time. And this is what M mode, what we do number of times is, look, this is thickened pericardium. Behind the pericardium, there is a fluid. So we have thickening of a pericardium and we have a fluid behind it. And when we look at this, we always go back and look at the Doppler flow patterns of this entity, which is known as effusive constrictive pericarditis. And what are the features of this constrictive pathology is? We virtually find the same feature as we find in pericardial tamponade, and they are exaggerated to a large extent, almost the same as they were earlier. Now, what does it mean by? If you really ask me, what exactly I'm trying to say, understand? Initially, my heart was engulfed with a fluid all around the heart, or a ball of a fluid, or a balloon of a fluid around my heart, not letting the heart to expand. Now the fluid has absorbed, but it has formed a shell kind of a thing around my heart along with the pericardial effusion. And when we see this particular phenomenon of pericardial effusion, along with the constriction, apart from the features which I taught you about pericardial tamponade, and what were the features I taught you about the pericardial tamponade? These were the features which we talked about pericardial tamponade was two dimensions, moderate to large pericardial effusion. Now pericardial effusion is present with thickened pericardium. We have a RA systolic collapse, we have RV systolic collapse. We do not find any collapse. But we find a respiratory variations in RV and LV volumes. IVC is plethoric and respiratory variation in Doppler flow pattern across these particular chambers. And when we see this Doppler flow pattern apart along with this chamber, and we look at the findings of thickened pericardium along with pericardial effusion, we start suspecting effusive constrictive pericarditis. Now, we had the constriction, we have tamponade where the structure were compressed. Now we develop a effusive constrictive pericarditis where another factor which develops is the relaxation ability of the LV cavity gets down dramatically. And how do we look at restrictive constrictive pericarditis giving to relaxation of the LV, which gets hampered? Normally, E prime septal of LV cavity is less than E prime lateral of the LV cavity. In effusive constrictive pericarditis, the reversal happens. E prime becomes taller, and lateral E prime becomes smaller. Why it's happening so? Because during relaxation, when LV is in diastole, the interventricular septum can move toward the left-right ventricle. But the left, like lateral wall, has nothing to move on the outside. It found a shell of a pericardium, which is getting thickened over a period of time along with pericardial effusions. So there is no tamponade. There is no like no collapse of a LV, RV, other factors. Other features remain more or same, but patient develop this feature of relaxation abnormality, which is found in like form of E prime septal versus E prime lateral. And the most important thing is when we develop a full-fledged constriction pericarditis, the other feature which develops to a large extension is expiratory reversal of flow in the hepatic veins. As soon as the first beat of expiration happens, which is seen over here, the flow reverses happens from IVC to hepatic vein, which is shown in M mode kind of a pattern. Look, all flow during systole and diastole always happens towards hepatic vein to IVC. But when effusive constrictive or pure constrictive pericarditis develop, this feature start reversing where IVC gives rise to fluid back into the hepatic vein with first beat of expiration. And that is very, very important in subset of populations. Here is normal and here is abnormal. So if I have to conclude with the features of effusive constrictive pericarditis, we find thickened pericardium without pericardial effusion, or respiratory changes in LV and RV volume, reciprocal respiratory changes more than 25% in LV and RV, IVC is plethoric, hepatic venous flow pattern, septal E velocity is more than lateral E prime velocities. And these features give rise to features of effusive constrictive pericarditis. Why we talk of effusive constrictive pericarditis, many of you must be thinking, look, somebody develops a effusive constrictive pericarditis. How does it make a difference whether he develops a constriction or restriction? Well, the most important part of this slide is if somebody develops a effusive constrictive pericarditis, that is one point. It could be a transient constrictive pericarditis if dealt with caution. What does it mean by dealt with caution? Means if I happen to see a patient of effusive constrictive pericarditis, it means the patient has not gone into full-fledged constrictive pericarditis. And when it has not gone to full-fledged constrictive pericarditis, the anti-inflammatory drugs, especially the steroids, they really help you in reversing this process of effusive constrictive pericarditis, and if they become normal, we call them as transient constrictive pericarditis. So it's important for the reason that it is treatable, non-invasive, with medical science, with medical therapy. On the contrary, if full-blown constrictive pericarditis develops, that needs a ripping of a pericardium, which is a large procedure to deal with in surgery. This is one slide again to tell you about the septum E prime, which is taller than lateral E prime. We often call them as paradoxical annulus, annulus reversus. The number of names has been given to it. And take my word, this is the most sensitive sign of effusive constrictive and constrictive pericarditis. And another important feature is apart from respiratory flow, the important feature is that hepatic reversal of flow, hepatic vein reversal of flow in early diastole. So we moved on from a pericardium, pericardial effusion, pericardial tamponade, effusive constrictive pericarditis to constrictive pericarditis. In constrictive pericarditis, features are more or less same. Thickening, there is no fluid. Normal LV-RV size and function, LA enlargement, flattened diastolic motion, abrupt posterior motion of the ventricular septum during early tricycle, dilated IVC in hepatic veins, and the most important feature is diastolic Doppler finding, respiratory variations, and on top of that, the TDI velocity of septum is more than the lateral wall, which we call them as annulus reversus, and along with the hepatic reversal flow. One word about RA inversion. What do we mean by RA inversion? We have seen this phenomena very commonly in day-to-day practice. This RA inversion happens because our right atrium is the first structure which gets affected whenever the pericardial tamponade happens. So what exactly happens? Why it happens? Because RA has got the lowest possible cardiac chamber pressure, that is 5 millimeters of mercury. And that leads to a collapse of RA, which is known as right atrial inversion or RA inversion. So I'll stop it over here and take up your questions, because I'm sure like many people will ask many questions. So I'll just stop and take up your questions one by one, because it's a large topic, but topic is very interesting and very easy also. So let me just stop it over here and go to a questions one by one and just share the same thing over here. You can raise your hand if somebody want to ask some questions. Dr. Amandeep Dhanju. Atindra Narayan. Go ahead, Dr. Atindra.
Good evening, sir.
Good evening.
Sir, it is the normal physiology that during inspiration, the right-sided flow will increase and left-sided will decrease.
Yeah. Tell me what you say.
Sir, it is a normal phenomena that during inspiration, the flow to the right side of the heart will increase and that of the left side will decrease.
Correct.
So, in cardiac tamponade, what is the except of ventricular interdependence? What are the different other things that we have to look for?
In which condition?
Sir, in cardiac tamponade.
Cardiac tamponade. Don't mug up things. Just try to understand what is cardiac tamponade. Heart is enclosed around a big shell of a bubble in which lot of fluid is present and heart is swinging in that.
Right.
Correct?
Yes, sir.
So this large bubble where the heart is swinging is not letting the heart to expand. And wherever this intra-bubble pressure, intrapercardial pressure is more than intracardiac pressure, that is showing a collapse. That's one. Collapse of RV during diastole and collapse of RA during systole. Correct? Now I take an inspiration. So what exactly happens when I take an inspiration? My respiratory flow velocity across tricuspid valve will increase.
Yes, sir.
But there's no place for the heart to expand because of the large amount of fluid which is present around the heart. So what does the heart does? It shifts the intraventricular septum towards the left-hand side to accommodate that inspiratory flow of a blood into the RV and RA. When you shift the heart to the left side, the flow in left ventricular starts decreasing. That is known as interventricular interdependence. Now I expire, I breathe out. The septum immediately shifts back to the right ventricle and the flow across mitral valve start increasing. And remember during medical time, what we used to learn was we take a deep inspiration, the pulse used to disappear.
Yes.
And you expire, the pulse used to come back. Why the pulse will disappear? Because deep inspiration, the flow across the mitral valve is reducing at level of mitral and aortic valves. And this variation is more than 25%. Like the flow velocity is 100 meters in expiration. In expiration, it will be 75 or less than 75 centimeters per second. That clear?
Yes.
Now this fluid, if it gets localized, it compresses chambers. If the intracardiac pressure of the fluid is more than 120 millimeters of mercury, that is more than systemic, even it will collapse the LV.
Yes.
If it's more than 25, it collapses the RV. If it's more than 5, the first structure which get collapsed is RA, and that is what is known as right atrial compression or inversion. And this right atrial inversion can happen with a very small amount of fluid. And that is very commonly seen number of times when we are doing echocardiography. People who has got pericardial effusion secondary to congestive cardiac failure, they often find the RA collapse. It does not mean that we are going to put in, we are going to tap those fluids, because we have to correct the basic pathology to look at that why this fluid is collecting. Hope I made my
Yes.
answer very clear.
Yes. Thank you, sir.
It's a pathophysiology, it's a physiology. What exactly is happening in the heart? Avnish Bulgar.
Hello.
Avnish, go
Hello,
ahead.
sir. Yes, sir. So, in few reports while reporting pericardial effusion, I have noted that they have mentioned pericardial effusion 1 centimeter in apical area, in posterior 2 centimeter. Should we report that, or we should whether to tell just mild, moderate, and severe?
No. If it's a fluid which is seen across various windows, 1 centimeter, 2 centimeter, 3 centimeter, whatever it is, I always mention, but at the same time, I'll add one more thing. Apical window, at what place? Along the LV free wall, apically, or in relation to lateral wall. Similarly, if I'm doing a subcostal window, I'll say anteriorly or posteriorly. Similarly, I'm doing in a plaques window, I'll say whether anteriorly or posteriorly.
Okay.
So we have to be very clear what we want to convey to a person. Correct?
Yes. And
Uh,
can we? Yeah. Sorry, sir.
Go ahead.
Can we tell? Can we tell volume of pericardial effusion by any way?
We can
Is
suspect,
that
but the
yes?
assessment would be very wrong. Now let's think of a practical solution, a practical situation. When we do an echo, in which position the patient is lying?
Left lateral.
In subcostal window?
Supine position.
Supine position.
Yeah.
So in subcostal position, if the patient is lying in supine position, if I happen to see fluid anteriorly
It will be
and there's no
miscalculated.
fluid posteriorly, will you accept it?
No, sir.
Okay. Now you got my answer very clear.
Yes. Yes.
Because the fluid will be collected more on a posterior side or dependent side rather than collecting on an anterior side.
Okay.
Dr. Rariwala Mahajan.
Good evening, sir.
Good evening.
So please explain RA systolic collapse and RV diastolic collapse.
Okay, wonderful. Let me just give me Ravi. I'll go to some presentation where I can show you the live demo. How do they look like? I think that'll be a better solution rather than showing or talking without showing any AVI clips.
Yes, sir.
All right. So I'll be showing one by one a clips of this patient. Here is Ellie. Ellie is almost 26 millimeter. Now look at this patient who has got an M mode across interventricular septum and posterior wall. We are not bothered about interventricular septum posterior. Look at the amount of fluid which is seen over here. And we have to see during diastole, not in systole. This is systole. So I'm not bothered the fluid over here. I'm more bothered with the fluid over here.
Yes, sir.
Correct?
Yes, sir.
But during diastole, anteriorly we see small amount of fluid. But we do see anteriorly the fluid which is present over here, from here to here.
Yes, sir.
This is Plaque's window. So if I happen to see a fluid in posterior side, this is more important rather than anterior side. This is now small amount of fluid anteriorly and large amount of fluid posteriorly.
Yes, sir.
Now look at the movement of this interventricular septum. This fluid is separating out larger during systole rather than diastole. Don't concentrate. This is something different which is happening in this patient. Now we have measured the fluid posteriorly, which is almost 4 centimeter, 3.5, and anteriorly is hardly any 1 centimeter of fluid. Now somebody asked me this question, whether I should label this fluid as mild, moderate, or large. Possibly I am not the person who can say how much the fluid is there. The pericardial fluid is there. Look at this respiratory variations. There's hardly any respiratory variations in this patient. Mitral flow velocity, there's not significant change as there. Aortic, no significant changes there. Tricuspid, no significant changes there. But now look carefully what exactly is happening. I'm going to stop this slide for you. It's a long clip. Now I'm moving my clip gradually. This is systole,
Yes, sir.
correct? This
Yes,
is
sir.
diastole. And look, this RA is collapsing during systole. Normally, RA will show only one contraction. Now, look, at every cycle, it's showing two contraction. One is diastole, one is systole.
Yes,
If you
sir.
want, you can put an M mode right across this RV to look an M mode across RV, RA. So it will show a contraction both during diastole as well as systole. And this is the first chamber to get collapsed. Look, there's a pericardial. Somebody asked me, how do I report? If you ask me to report, I'll say the fluid across LV free wall on the lateral side in relation to lateral wall is this much, anteriorly is this much, and RA size is this much. So I'll not comment on this, but I'll comment on this. Now look at very carefully. Let me stop it for you. And we'll try to find where this collapse is happening. Now, where's the cursor? Cursor is in systole.
Yes, sir.
So we can put an M mode to look at this collapse of RA during systole. Similarly, what you can do is, if you go to Flax window, this is what I was trying to do. What I've done is, I've gone to Pearson short axis view at aorta. Then I've done it. This is RVOT, proximal
Yes, sir.
RVOT. So I've done an M mode during proximal RVOT over here. Now I'm trying to find whether this RV is collapsing during diastole or not. So this is RV. This is contraction of the RV. This is again relaxation of the RV. If I put my line over here, look, RV is contracting during diastole or not. So this is how we find it out. This is not contracting. If RV is contracting during diastole, what will happen? In this factor, you will find systolic contraction, then again back, then again diastolic contraction, then again back.
Okay.
So this is how we look at RV outflow tract, whether it's getting collapse or not during diastole. Because in systole, RV will be collapsing. RV would be collapsing in diastole. So we have to see a reversal of contraction in collapse patterns. So this patient has got nothing. It has got a large pericardial effusion with only RA collapse rather than any other collapse of the structures. Let's move further. Let's see what else is there. Now, look, one important thing which I told you. This is E prime septal, which is 5. This E prime lateral is 6. So if it's a effusive constrictive pericarditis, there will be not a collapse. It will start showing E prime septal as 5. This is 6, so it becomes 5 and that becomes 6.
Yes, sir.
And the most important part of this patient was in congestive cardiac failure, left ventricular hypertrophy with congestive cardiac failure, with evidence of pericardial effusion, with caudal rupture. And that was a diagnosis of this patient. Look, this patient has got a severe MR along with the caudal rupture.
Yes, sir.
So that was a diagnosis where only RA collapse was present and there was no other feature. IVC was plethoric, RA collapse was present, and that's all this patient shows with evidence of most probably large pericardial. Now,
Yes.
this factor cannot be explained. This features of pericardial effusion cannot be explained with caudal rupture only. So we have to tap this fluid to get an answer why this fluid is present. Look at the hypertrophy. there was a caudal rupture, there is RA collapse. In this subset of population, obviously, we are not in congestive cardiac failure, and the treatment of choice would be IV fluids to increase my intracardiac pressure to take care of this pericardial collapse, RA collapse, and then try to tap this fluid for a cause of pericardial epilepsy.
Yes.
Dr. Sharvan Kumar,
Good evening, sir.
good evening, Dr. Sharvan.
Sir, actually, we are discussing about intrathoracic pressure, all the physiology, sir. So, in case when we alter this physiology, like in case when the patient is intubated, we give positive end expiratory pressure. So, we increase intrathoracic pressure, sir. So, how are the dynamics will change, sir? RV pressures and LV pressures.
They are horribly changed. It's a topic by itself. I can talk you the topic in length, how bad the ventilation is for the heart.
Sir.
I'll show you a glimpse of that. I can't tell you the complete, just give me a second. I talked about this topic number of times in number of conferences.
Sir.
I'd say ventilator is real derogatory for cardiac functions. I'm trying to locate that the topic. Just give me a second,
Yes, sir.
because there are more than 140 topics in this computer right now.
So we can discuss at the end of the class, sir. You can finish the
Yeah,
others.
we can. Yeah, let me finish, and then I'll try to show you like how bad this echo in intensive or all right. Just give me a second. I'll be fine. We'll be able to find out after the class.
Okay, sir. Okay.
Dr. Muhammad Ali Qasim.
Good evening, sir. Sir,
Good
you
evening.
can hear me?
Yeah, I can hear you, Dr. Muhammad Ali Qasim.
Sir, in case of cardiac tamponade, there is a RV systolic error more than one third of the diastolic, and also RA systolic error more than one third of the systole. So why
Correct.
the duration is one third? No, why not two third or whole of the
At
length?
least one third. The word is at least one third. It could be two third. It could be complete collapse also. It all depends how much the pressure of intrapericardial cavity pressure versus intrachamber pressures. If there's a complete collapse of RA during suppose RA gets collapsed during systole. If there's a complete collapse of RA during systole, what will happen? What is the function of RA during systole? Dr. Muhammad Ali Qasim, what is the function of RA during systole? Are you there, or some connection is broken? I think the connection is broken. Let him come back. We'll answer this question again. Anybody else? Some questions? Dr. Nitin Pare, are you there? Dr. Nitin Pare? Dr. Prabhu Dayal Vishwakarma.
Yes, sir.
Good evening, Dr. Prabhu Dayal. I just wanted to ask you one question. I hope you understand what I talked about in last almost 1.5 hours. Suppose a patient of pericardial tamponade come with plethoric IVCs and congestive cardiac failure, grossly engorged veins and everything. What would be your first line of treatment for that patient?
Sir, if patient in cardiac tamponade, then increase the volume of the fluid.
Pardon, what you will give, like first line of treatment, what would be there for that patient? Suppose you diagnose somebody as pericardial tamponade. You have like features of plethoric IVC, engorged neck veins. Patient is dyspneic. RVRA, they definitely show RV shows a diastolic collapse and RA shows a systolic collapse. So, what will be the first drug you would like to give? Apart from tapping, I'm sure you'll do a tap. And if you don't do a tap, if you refer a patient, pardon?
Then increase the volume by giving the fluid.
You will give a fluid or you will give Lasix? Okay. Now my question goes to the same question goes to Dr. Chandrika Naik.
Good evening, sir.
Good evening, Chandrika. What do you like to give, Lasix or a fluid?
So Lasix infusion.
Lasix infusion. Okay. Dr. Lalit M. Bhardwaj.
Sir, will give IV fluids.
Why will give IV fluids? Why not Lasix? Dr. Chandrika is sitting across you and she says, I want to give Lasix and you want to give fluid. If I am the patient, how do I decide?
If there will be less fluid, if patient is dehydrated, the collapse will be more, what I guess.
You, as far as fluid is concerned, I agree with you. But as far as the rationale of giving a fluid is not correct. Dr. Rajesh Kumar Tiwari.
Sir, actually we are giving IV fluids because intracardiac pressure is less than pericardial pressure.
Perfect, Rajesh. That's what I was trying to teach you for last 1.5 hours. What is bloody pericardial tamponade is the intrapericardial pressures are becoming more than intracardiac pressures. Give a Lasix, what will happen? I'll reduce the intracardiac pressure much more than intrapericardial pressures. And the drug of choice in this subset of population is load up the patient with IV fluids. Despite the fact the IVC is plethoric. Correct? Dr. Chandrika, you got the answer?
Sir.
Perfect. Now, let me move on to one more question. The question is, how much pressure is required to compress LA to produce pericardial tamponade? The question goes to Dr. Lalit M. Bhardwaj.
What, sir? Can you repeat, sir?
How much pressure is required to compress LA to produce pericardial tamponade?
LA is not covered with pericardium, sir. I am not getting.
So, what will be your answer?
So because LA is not covered by the pericardium, it
So we
requires
don't
at
look at
least
a
10 millimeter.
No.
10 millimeter of mercury.
Sukhminder, Dr. Bhardwaj, we do not look at the pericardial tamponade on LA because there is no pericardium on the LA.
Yes,
Yes, sir.
it's covered by pericardium.
It's not covered by the pericardium.
Yes, sir.
Got it? All right.
Yes, sir.
Now I have to go to
Yes, sir.
one more questions because look, this is physiology. How does it work? Dr. Adnan Bashar. Adnan, are you there?
Yes, sir. Yes, sir.
Adnan,
Good evening.
I got a patient of constrictive pericarditis or pericardial
Yes,
tamponade
sir.
whose IVC is small.
Okay.
Pericardial tamponades, and his IVC is smaller in size. So, what is the cause of small IVC in this patient?
Uh, this patient may be dehydrated due to any cause.
You have to clearly clarify it. What is the cause?
Uh, Patient may get unjudicial diuretics like Lasix or
Perfect.
some drugs.
Like
This
the
may cause.
first reaction of ours is as soon as we see engorged veins in a patient and dilated patient in congestive cardiac failure, breathlessness, the first reaction is always give Lasix. So we often see
Yes,
patients
yes.
presenting with pericardial tamponade with smaller or normal IVCs. Is that correct? So if you happen to see a congestive cardiac failure, so ask for a history first, do an echo, and then give Lasix. Okay?
Okay,
All
sir.
right.
It's I can supplement that. Actually, when I do CCU duties, it's a very good tool to assess the dehydration status or hydration status by seeing the IVC,
Right.
and which will also leads you to give fluid in this patient or not to give fluid in this patient.
Perfect. Perfect. All right. Next question goes to Dr. Malia Islam. Dr. Malia, are you there?
Yes, sir. Good evening, sir.
Good evening. Dr. Malia, why the reversal of flow in hepatic vein happens during constrictive pericarditis?
Sorry, sir. I could not hear the question.
Why the reversal of flow happens
Right,
in
sir.
hepatic veins during first beat of expiration in constrictive pericarditis? No idea. Let's move on to Humaira Akhtar.
Good afternoon, sir.
Good afternoon. Is it evening or night rather?
Sir, good evening, sir.
Good evening. Good evening.
Sir, during inspiration, blood goes from hepatic IVC to RA. So, RA pressure, so reversal of flow occur at that time.
During inspiration, the blood goes from hepatic vein to IVC,
Yes, sir.
then RA to RV. My question is, during expiration first beat, why the flow reversal happens from IVC to hepatic vein?
Due to, sir, interventricular dependence on RA pressure.
Perfect. Now explain in detail.
Sir, in expiration, blood goes from pulmonary vein to LA to LV. So, interventricular septum is shifted to the right side, and blood is go back to LV to RV to RA, and inferior vena cava to hepatic vein.
Correct. Perfect. I hope everybody could understand why it's happening. Because heart is enclosed in a shell of a calcium in constrictive pericarditis. So whenever the person expires, the first beat of expiration, the interventricular septum shifts from LV to RV, and there's no place for the blood to go because IVC is plethoric. The only place where the blood can reverse back is in hepatic veins. And this is the most important sign for constrictive pericarditis. Excellent, Myra. God bless you.
Thank you, sir.
All right. One more questions, then we put a break. Dr. Prabhu Dayal Vishkarma has joined from two angles. Please do not do that.
Hello.
Please disconnect one, Prabhu Dayal. You are joining
No,
from
sir.
two angles.
No, sir. I am joining since evening.
No, you have joined the internet from two connections.
Yes, sir.
So stop one.
Okay, sir.
Dr. Muhammad Masudar Rahman.
Good evening, sir.
Good evening.
Sir, in constrictive pericarditis, the pericardial thickening occur and calcification occur. Can we differentiate it from pericardial fat, sir? Yes, there is the same echogenicity in fat and pericardium.
Thickened pericardium will invariably be hyperechoic because there's a lot of calcium in the pericardium. Whereas the intrapericardial fat, which is outside the parietal pericardium, will not have the same intensity as thickened pericardium. And still you have a doubt. I'm not saying 100%. If you have a doubt, get a cardiac CT done.
Thank you, sir.
All right. Any other questions? Questions? Every one of you understood pericardium very well? So all of you
Yes,
have
sir.
become masters of pericardium. And one more thing I'll say, you will not find all features of pericardial effusions and other things in all patients. You may find less, may not be all features. Some features are found, some features are not found. So in that case, you don't give it an answer question. And look, pericardial effusion is there or not, that particular pathology is there or not there. So don't do that, look, it's there or not there. So I'm taking all of your attendance. Somebody want to ask some question? He can open up his mic and ask me a question.
Sir, not related to this topic, but one patient was there, very obese, not able to get any windows. So what should be done in these patients? And they are in the ICU, so we are not able to change the position also.
What exactly are you looking for that patient?
Patient is a known case of IHD and he was in sepsis. He had a cellulitis of left leg and he was in hypotension. So wanted to look for his IVC and his systolic and diastolic dysfunction mainly.
Okay.
But no windows.
So majority of these people, if they do not have a good window, try to look for a right side of the heart.
Okay.
Look from right intercostal, right right axillary line. There you will find an IVC always.
Right mid-axillary line. Okay.
Then whatever the window you get, try to locate at your tricuspid RV free wall and septal or lateral free wall.
Okay.
If you're able to get a tricuspid free wall, RV free wall, at least you'll be able to see, just put an M mode to look at your TAPSE.
Okay, sir.
For a systolic function. For a diastolic function, then we are not really sure what we can do is. But for RV function, if you just put a line across lateral LV cavity, lateral LV free wall on the lateral side, do a MAPSE, you will get a systolic contraction.
Okay.
So by this right inter-axillary line, you'll be able to see IVC. Then whatever from place you can get it, try to look for LV and RV free wall. And through that, you can look at a systolic functions.
Okay, sir.
And number of times, what we do is, like, we just put a blind sample volumes. Pulse wave sample volume, wherever we could see a chamber. And we are not really sure which chamber it is.
Okay.
If it's a mitral velocity is relatively higher than tricuspid flow velocity.
Okay.
And that's how we try to get an idea how we are looking for LV, RV, and IVC status.
Okay, sir. And yesterday, with your suggestion, I got TRZ in 5 patients, so I could get it. In 2 COPD patients, I got more.
Yeah.
And rest of the at least small TRZ, I could get it. So
Yes.
I was probably lazy. In
I remember my boss used to tell me whenever I never used to find a TRZ, he says, Rakesh, you are hungry. Go eat your food, come back, and then you'll find a TR.
Yesterday, I could get it.
Yeah. And fortunately, you people have a very good machine. I'm talking of a period of late 80s when we used to do echocardiography. The transducer was almost 5 kg of weight. So hand used to get tired over a period of time. And even put on a patient chest, it was a real bulky transducers. Machines were almost 200 to 300, 200 kg of a machine, 250 kg of a machine. To roll that machine on the floor was a Herculean task.
Yes, definitely.
So, and then we used to have analog. We used to record in the cassettes. And then to report, we used to read those cassettes sitting in the lab, moving in fast forward, backward, slow, fast. And today we have everything available. You can take on a machine anywhere in your pockets.
Yes, yes.
So things have moved a lot. Anybody else? Any other questions before we call it a day? Some Dr. Sukhdeep Singh is now trying to join. Tell me what to do with this person. Let me welcome him and ask him a question. Good evening, Dr. Sukhdeep. Dr. Sukhdeep? Dr. Sukhdeep, are you there? All right. So let's break it over here. And we see you next week. We'll start with the basics of congenital heart disease on Wednesday. And Saturday, my senior colleague, Dr. Parashar, will take on your congenital stenotic heart disease. And the program will be coordinated by Mrs. Reena Dua, because I would be traveling at the time during the time when the class is going on. I'll be traveling to Sri Lanka. And I'll be reaching Sri Lanka hopefully by 10 o'clock. In case I get a time, in case my flight reaches in time, I'll be able to join before the class ends. And Friday, the class would be a little earlier. I'm informing you 1 week in advance. Class would be at 7:30 on Friday, 9:30 on Wednesday. So that's how the next week plan is. And we'll be covering both stenotic First, I'll be talking about acyanotic congenital heart disease and sequential analysis. And Dr. Parashar will show a collection of cyanotic congenital heart disease for all of you. With these few words, let me pay thanks to each one of you for excellently understanding the pericardium today. And especially, I really admire Dr. Humayra Akhtar, how beautifully she explained why the reversal of flow happens in hepatic veins with constrictive pericarditis. And that's what we look forward. If we happen to understand the pathology of a particular illness, it becomes very easy to understand what exactly is happening. And pericardium is not anything but is a game changer between intrapericardial pressure versus intracardiac pressures. So let me say goodbye, Shabba Khair, stay safe, and we see you next week on Wednesday at 9:30, dealing with sequential examination of congenital heart disease along with acyanotic congenital heart disease in regular practice. Bye.
Thank you, sir.
Thank you, sir.
Bye, everyone.
Thank you, sir.
Thanks, sir.